introduce her.
My name is Clara Lowy, and I'm a retired consultant physician from St Thomas's Hospital. My current address is 44A Rosemont Road, Acton, W39LY.
And in front of you, you have your submission. Is that true to the best of your knowledge and understanding? And do you wish it to stand as your evidence to the Commission?
Yes.
I wanted to ask you first a little bit about your experience. You're a retired physician. Can you just expand on what your expertise and experience was?
Right.
Is, please.
I was eventually had a chair in endocrinology and diabetes at St Thomas's Hospital as part of King's College. I had a special interest in diabetes and pregnancy and set up the combined pregnancy diabetic clinic. I also did the first UK survey on the outcome of babies of diabetic mothers for the whole of the UK. And perhaps the most important of all, in my view, is combined with a patient, I invented with her home glucose monitoring, which completely transformed the management of diabetic pregnancy. Diabetic women with type 1 diabetes would be admitted at about 32 weeks, and they would spend the rest of their time in hospital. As a result of introducing this, they were able to stay at home until the time of delivery.
Thank you. I want to just ask you a question which is related not to your expertise, but what you've said in your covering note, which is that you comment that you have difficulty accessing your GP practice. Now, just following on from the last witness, could you just tell the Commission in what way the difficulties are?
Well, it's difficult. If you have a problem that might not be an emergency, it's difficult to get an appointment. And on a recent occasion, I said, well, look, this is not an emergency, but I do need an appointment. Well, we've only got 2 appointments in this month, so we can't make one at all. So there are great difficulties. I may say that actually I was part of the Hillcrest surgery, which is Mark Spencer, and their performance, in my view, was poor, clinically particularly, not the nurses, but the clinic performance is poor, and I have just changed to the Mill Hill practice.
Can you perhaps expand and tell us then, in your view, both on a personal and from your experience as a physician, how would that practice, the Hillcrest practice, cope if it had to manage with providing an extended range of services?
I don't think they would cope at all, and I'll give you just an example of that. 2 years ago, I broke an arm and a leg skiing, and I couldn't go home because I had stairs, and I sorted out my own care privately, £2,000 a week, but I needed to have some information clinically sent to the home where I was with, and they couldn't even manage that for 3 days. So the whole delay for 3 days was because they were so incompetent in being able to transfer clinical information so that the home could accept me.
Now, in the body of your submission, and this is still on GP service issues, you raise several issues about how GP and hospital services should work together.
Yes.
First, you put it in the context of surgical follow-up care. Can you help us with what your concerns are about the monitoring angle and the communication aspect, please?
Well, I think there's relatively poor communication between hospitals and the community. And in the community, there isn't really much care. Physiotherapy, dietitian. When I asked my GP at the Hillcrest surgery, do you have a dietitian that looks after the diabetics? Well, we could call one. Well, that's not good enough. I mean, you have to have an integrated care system. We set up a diabetic clinic at St Thomas's where we had dietitians for diabetics, dietitians, the consultant themselves, registrars, teaching, nurse practitioners, podiatrist, eye screening, all in one centre. And what's interesting is in that sort of community where we all met once a week and discussed our problems, different patients related to different individuals, but we all understood that that worked. That sort of coherence just doesn't exist. It could exist in the community, but it's expensive. and nobody has really thought this properly through.
So how, in your view, does the planned reduction in acute hospital beds and how will it be impacted on, how will services be impacted on by the reduction in hospital beds and the increase in community-based care if it does actually take place?
Well, there has to be communication between the hospital specialist and the community. But the problem is that the community care just doesn't exist. And not only that, it's no good having a specialist nurse in one practice who doesn't talk to any other specialist nurse. She needs to be organised in such a way that she's within a community where they can discuss each other's problems. So, health centres, as Darcy suggested, and $1 billion sum of money spent on these sort of organisations would solve some of these problems, but it wouldn't be any cheaper. It would be just as expensive, but it might be better.
Now, one of the issues you also raise is late diagnosis of cancers.
Yes.
And you talk about GP late diagnosis being one of the issues. And if that's something that needs improving, how should that be done?
Well, the question it's about 20% of cancer diagnosis actually occur in A&E. So why is that? I think the answer is that if a GP has 10 minutes in order to see a patient, they're never going to get there because there isn't enough time. So I think the way to improve it is partly education of the GPs and partly having more time for that kind of activity. I mean, when I was running an endocrine clinic in St Thomas's, I always overran. My clinic went on till 6. Patients accepted that, although they had to wait longer. GPs can't really do that because they've got other activities.
So what impact do you say the proposed reorganisations will have on specifically the diagnosis of cancer?
I think it'll almost certainly make it worse.
And given that you've just said that a lot of cancer is diagnosed in A&Es, if there are less A&Es, again the same question, what will the impact be?
Well, the impact will be, I don't know whether the urgency care centres will be able to take up the slack on that, but I would doubt that. We have to put that back up to the GPs, but we've got to give them time.
Now, you raise as well the issue of the ability of members of the public to judge the quality of the GP. Now, does this become more of a problem? Does this become more important if more work is devolved to GP services?
Well, again, there has to be a bit more feedback between the patients and the general practitioners. And I think there is a problem here in that if you're sick and you want to see your doctor, the last thing you want to do is to criticise him or her. So there's a difficulty of being able to express your views and not being discriminated against. So I think it's a difficult problem, and I don't quite know how you solve it.
Now, just thinking about, you say that some of the issues that would previously have come under the scrutiny of a consultant are now moving towards GPs, and you're talking particularly in terms of follow-up appointments.
Yes.
Is that a concern for you?
Well, it is a concern because, for instance, if you have a chronic psychiatric condition like depression and you've been seeing the hospital specialists in that field, and that is now going to be transferred to the general practitioner who may not have any particular skills in looking after psychiatric services, that's not going to work very well. I think it's particularly a problem actually for paediatrics. I wrote to the Royal College of Paediatrics and Child Health to ask them about their views about how they saw the development of paediatric services, because it's inadequate. The training for GPs in paediatrics is poor and is recognised as poor, and they did actually set up a training service and then deemed it to be too expensive. So, and the college suggested that they did like bigger hubs with more specialists, but they also wanted to have consultants in the community and above all specialist trained pediatric nurses. They haven't happened. Now, the college at the end of this letter, very helpful letter, said, well, of course, we don't have any money and we don't have any power and we can only make recommendations that people can ignore.
So is the thrust of what you're saying that for GPs to do more, they require more?
Exactly.
Can I ask you, turning now to your particular specialism, you set out in your submission some of the issues around diabetic mothers and concerns in respect of babies and neonatal care. Can you expand upon that, helping us with where those women need to be, who needs to oversee their care, the setting and the risks, please?
Well, I think a whole lot of there's the preventative thing. So there's the question of education before women get pregnant. There's the question of the type 1 diabetics or insulin dependent who will probably still be attending hospitals, and they need to be in a combined diabetic antenatal clinic. But there's a particular problem with gestational diabetes. This is hugely on the increase, and particularly in Ealing and also in Europe. Something up to 30% of these women develop diabetes in pregnancy. Now, who's going to diagnose this? And not only that, but a woman who develops gestational diabetes starts off her pregnancy fit and well. I'm doing something really healthy. And then she said, well, we think we ought to do a test. And it came positive. So suddenly, a doctor or a nurse has thrown a disease upon them. And most patients are angry and say, but I don't have any symptoms. And then they're frightened because they've got a baby and they want the best baby. That needs careful handling. Now, what we're doing here is we're doing it possibly in the new configuration, either at Ealing or possibly in the general practice or in the health centre, and it's going to be totally fragmented. On top of that, even if you get that bit right, postnatally, these patients need to be followed up because about a fifth will have type 2 diabetes. And type 2 diabetes in the fertile age are more likely to go blind, more likely to need renal dialysis, more likely to have heart attacks. So they're a very vulnerable group. And in the configuration we've got at the moment, I think they'll get lost.
So at the moment, in terms of the Ealing maternity service, what do you say about the service, if you know, about that provides for that group of women?
I'm talking from my own experience, so I have not had any direct dealing with the Ealing maternity service, but I understand they do have a combined diabetic clinic. I think it should be coherent, I think it should stay in one place, and it should perhaps be linked up with the local GPs who should have much more understanding of the severity of what seems to be asymptomatic disease.
So following on from that, are you able to help with a general view about whether or not you consider the maternity unit at Ealing should be shut or should remain open? I
think the maternity unit in Ealing should definitely be continue, and I think should be expanded. We've got an expanding population, and not only that, but we've also got an expanding population of diabetes. So this is an area that needs to be conserved.
Finally, can you help with any other issues specific to your areas of expertise that you think may assist the Commission?
I think I've said enough.
Okay, I'm very grateful. Please wait there, there may be questions.
Yes, thank you very much. Two questions. One is, you make an interesting point in your written submissions about the need to precede reorganisation and reconfiguration, whatever you want to call it, with some kind of in-depth pilot. Now, I'd like you to expand on what kind of in-depth pilot you would conceive in that situation. One other question. You talk about integrated hospital and community, and you describe the various expertises which would be gathered in such a system. I just wondered if you were able to make a comment on the original notion of polyclinics, which has been mentioned today, but again was mentioned last week as well. So those are the two questions.
Well, my great-grandfather was a chap called Charles Booth, who was a philanthropist. And if you go to St. Paul's, you'll find one of the things he says is that if you ever want to move forward, the first thing you have to do is have facts. And if you want facts, you've got to do you at least got to do a pilot. He did a pilot looking at the life and labour of London in 1900, and this was out the old age pension came about. But Therefore, you need to have an in-depth assessment of just where you want to go, rather than rolling out something over the whole of the UK. I think that's a point I want to make. The second point...
No, sorry, just a moment. That's an assessment. Of course, they'll say they've done an assessment. A pilot usually is some sort of practical implementation, so you can watch how it goes on the ground. Did you mean that?
Yes, I think I do. But how you set up that? There was a pilot set up in Hammersmith looking at over 70s, and I think it was diabetes and hypertension, and a number of GPs joined together to sort out a coherent plan, and it was actually working very well. It was reported in the BMJ, but it sort of got lost. So yes, it has to be on the ground. I don't think it has to be a paper exercise. That's useless.
Right. Second question, polyclinics, do you have?
I think a polyclinic is a good idea because A, it allows GPs to interact with each other, and also for nurses. Now, nurses are crucial and they're cheap compared with doctors. They need to interact with each other too. And they have to learn from each other as well as from the whole community. So I think polyclinics is the way. I don't think that an individual single-handed practice can really, in modern society, function sufficiently well. When I retired, I was fully NHS. Lots of patients, diabetics, said to me, "I'd like to see you privately." And I said, no, because I'm working as an individual. I don't have the specialist nurse. I don't have any of the ancillary services who are just as important as I am, and possibly more.
Yes, you refer in a general heading about how you judge the skill of a GP. You make some interesting points about psychiatric conditions, which obviously are part of the caseload of GPs.
Yes.
And you make the point there's been a 17% reduction in hospital psychiatric nurses, but only a 1% increase in community psychiatric nurses, which I think is a very valid point. I mean, do you have any other awareness and knowledge about the relative treatment of mental health conditions in primary care, and possibly a need for further training and development?
The answer is I have no personal, I mean, these are figures that I've taken off, that these are publicly available for everybody. But I think we have this mantra of saying everything can happen in the community and be so much better for patients, and then we don't actually put the staff there. And I mean, one of the things that is so patently obvious, that all the failing trusts are short of staff and have too many agency staff. And agency staff, I don't know whether any of you have worked with agency staff, but it's a nightmare. I can elaborate, but I won't.
Thank you. Just two perhaps unrelated questions, if I may. The first thing is, I ought to start with a preamble. I actually come from a polyclinic background. I started I worked in a large group practice, and 20-25 years ago we peaked at about 8 or 9 equivalent hospital outpatients training. And I think my antenatal clinic was the biggest one in Hounslow hospital, the number of people going through. So you can see I'm adapted that way. And also, I have to be honest, I'm not prejudiced against the hours and as hospital services being provided. I think they could bring, with the right services, very fulfilling medicine to practice, and actually bring doctors who want to work in general practice to use their training and be fulfilled. And also I would say Hounslow, which is the CCG where I was working, I think is the forefront of building these services. And one of the services they're proposing are 3 levels of diabetic care, including insulin initiation, which I was just dabbling with before I retired. Now, that as an example, my one worry I have is, and that of course is important, I believe, I think we would agree, because of the sheer numbers of diabetics, that they patently cannot be managed all in hospital outpatients. However, my main concern is to do with training of diabetic specialists. Because my fear, if it all comes our way, although it's great to do and very, very interesting, but you need time as you're around. Who's going to train the people that we go to for advice, because they're not seeing anybody?
Well,
now, what's your feelings about that?
Well, I think training is crucial, and how you set it up is probably expensive, and that's why it's often been neglected. How you train people, probably the hospital hub should provide that service of training all manner of things. It just doesn't happen. I mean, I went through the era of when specialist nurses first came into being, and as consultants, we recognised that nurses were absolutely crucial. The one thing is, doctors are supposed to get rid of your disease. Nurses are perceived as helping you to cope with your disease. So they have a very different role from the doctor in many ways, and therefore they need training. Just who that training should be, I'm not so sure, because I think the nursing fraternity and the medical fraternity and the physiotherapy fraternity are all very separate, and I'm not sure that they really got their act together to try and come into one unit, and that hasn't been thought about.
Now, obviously that specifically to Ealing Hospital, because it serves a population, I can't remember the exact statistics, with the highest ratios of diabetic patients.
It's huge, and what's more, it's going up. And these are young people now. Diabetes, type 2 diabetes, is now affecting a young population, and therefore they're going to go blind. They're going to have renal problems. They're going to have vascular problems at a much earlier age than was the case previously. So, and nobody's really thought about how to deal with this. There's also a major thing on diets, eating, all sorts of preventive process programs that ought to be in place and are not. But the polyclinic could be a source where this could take place.
I hesitate to make you work even harder. Just shifting a bit, this is, as others will have heard this morning, a hobby horse of mine. Again, touching on medical politics. You've been a professor at one of the great English institutions, St Thomas's Hospital. And I can't get out of my mind this map where we have all, and St Thomas's, I target St Thomas's as well, because it's one of that circle of hospitals in the centre. What do you think is stopping St Mary's or some is coming this way, where we have this wonderful catchment area of people to treat, and especially in diabetes? My theory is to do with medical politics. I wonder if you have any thoughts on that.
Yes, I do. It's all to do with private practice. At St Thomas, I was a junior doctor at the Hammersmith Hospital with a most fantastic academic setup. I then became a consultant at St Thomas's, and they were all busy going off and doing their bloody private practice, right? There was a time when St Thomas's might have moved to Canterbury, but the staff didn't want that because the private practice would have gone down the tube. So I think private practice is still a major problem in holding the bit in the middle, so to speak, together. For instance, if you went to the Hammersmith ward rounds, the open ward rounds, they were fantastic. But at St Thomas's, they didn't turn up, which is the senior staff, or few did. But it didn't have the same atmosphere, didn't have the same way of discussing things. I mean, the level of academia fell. That's my personal view, mind you. My consultants at St Thomas's might not agree.
Thank you. Clara, thank you very much indeed.